Hello, good evening, or good afternoon, good morning, according to your time. Today we are going to discuss together, live discussion, summary calls from April 2018. MRCS Part A recalls those who are going to the exam of September 2024 or going later exams. I think it's time for recalls to start. So I like to share some free sessions for recalls before your exams. Before we start, maybe some, I know many are already in our Telegram group or on our course group, but still we have many guests today. And I'd like to welcome all of them before we start. And just a short introduction before we start going for the discussion about how we go through our discussion for recalls or our course in general for MRCS Part A preparation. We introduce as MRCS Made Easy. I'm Dr. Ramy Youssef, the owner and the founder of MRCS Made Easy since 5 years. We introduced Part A and Part B courses for preparation for MRCS. Let's today take a short note about MRCS Part A. We give 4 months course. Our discussions are live discussion, whatever for MRCS or for the recalls. Most of them are live discussions. We give you a full drive of course materials in your drive. You have an access for them anytime till your exam. Plus we offer the, after we finish the study materials, we go for the recalls course for 6 weeks before the exams. You have a separate and private Telegram group, so you are allowed to discuss anything 24 hours with the mentors responsible for the course. This is summary about the full course we have. Then we simply go for, this is the schedule of the full course. We used to do the orientation at the start of the course, followed by question bank discussion. Before you go for the question bank discussion, which is twice weekly, you have to go for a lecture. Okay, so what you're going regularly to do is that you go for lecture, then the second day or the next day you go for a discussion question bank, lecture, question bank, lecture, question bank. This takes about 2.5 months, followed by 6 weeks or 1.5 months for recalls discussion. The 6 weeks recall discussion schedule will be like that. What you can say, you can see in front of you now. We go for discussion about 3 times weekly, but actually we work more than this. We work almost about 4 to 5 times weekly. Sometimes we do 2 sessions per day. So through this time, you are already in a journey to your exam, the 6 weeks before your exam. As long as I'm free and I have no work schedules, I go with you. Even sometimes we go for 1 hour if I'm free between surgeries, or if I have free spare time, we can go for 1 hour discussion, and then you take break, come again after 2-3 hours to take for 3-4 hours. The few days before the exam, we increase this time. We can stay together about 3 to 4 hours going live discussion. After all of this, even if you are not studying, self-studying alone, which is the second column here, like you are revising the other question bank from the online question banks or on the Drive question banks. From the live discussions we do together, you don't need anything else. Sometimes you can go for the exam with this live discussion because we repeat and repeat and repeat the question until it becomes so familiar to you. So you go for the exam even without self-study. But what I recommend, after you finish the session, you go for it again, increase the speed to 1.5 or 2, listen to it and write your notes and prepare yourself for the next discussion as well. This will help you more and more. Let's go to start our April. Now, طبعا يعني for sure I'm talking to those going to September now. You should already studied and get ready for the exam after 6 weeks. So we are going to discuss live discussion of April 2018, paper 2, special because we have this paper full scenario recalls, and I always prefer, and I always say this for my candidates, study the full scenario recalls first, and after you finish them, whatever their order, their years, you can go back for incomplete scenario recalls. It will be so easy for you. You already know the full complete scenario, even if you don't have the full scenario for these exams. So you will not waste so much time in searching about incomplete scenario and incomplete options, which will waste your time more and more if you started with it. So finish the full scenario. And then when you go for the incomplete scenario, you remember, yes, when he just give you a note like this, there was a scenario in the exam about a child, 7 years, limping. So yes, I know this scenario from April, from September, from January 2022, from any exam. I have the full scenario about this child, 7 years, limping, and so on. And the answer was Pertus's disease as an example. So don't waste your time going to incomplete scenario exam until you finish the whole complete scenario exam. So we have many complete scenario exam. We have all 2021 exams full scenario. We have 2020 September exam full scenario. We have from 2022, 2023. Many of them we have almost complete scenario exams plus April 2018. If you finish all these exams, after you finish, you go back for 2017, 2018, 2019, the rest of exams of 2022 and the 2023, the incomplete scenario. So it will be easy for you to complete the scenario from your mind. How we go through recalls, I always let all of you just raise your hand. Everyone will take 2, 3, 5 question, whatever. And then I discuss with you the scenario. Okay, and if there is any other options, the why we didn't choose these options in some questions, and some questions we just to go for the right answer. And some question we can illustrate the other answers, why and when to choose it. And if there is any similar scenarios with different answers, we can discuss it. So we just complete a fully illustrated scenario as well. Some scenarios just have the answer like numbers or something like this. So you just go for the number. So no need to any illustration, but some scenarios give you options. So you have to differentiate why did we choose this option. Everyone also is asked to tell me in most of the scenarios where is the key answer, keyword, or key phrase here that let you choose this answer. So when you concentrate on this word or this phrase, so when you go for the real exam, your eye will only catch the keyword or the key phrase and then go direct with your eye, jump on the answer. Okay, are you ready to go through the recalls now?
Yes.
Yeah,
Okay,
ready.
so what I need from you that you raise your hand, okay? So I can choose one by one how to go through the questions. I need as many as candidates to participate in reading the question and answer the question with us. Who's ready to go for the answers with me?
Sure.
Just raise your hand, please. So you can say who is going now to say. We can make like everyone can take 5 questions until we finish as many questions and the exam. Who raise hand to start with us?
Okay, I will start.
Okay, we have Dr. Ali. I need more to be ready. Dr. Muhammad Al-Tayyib. Just keep raising your hand so I give you your turn, please. Okay, Dr. Sana, Dr. Adil as well. Okay, let's start and waiting for more and more to raise their hands until we go. Okay, Dr. Ali, are you ready?
Hello, everybody. Can you hear me, Dr. Ramy?
Yes, I can hear you, Dr. Ali. So you can start the first question, please. Just read the question, read the answer, and tell me the answer.
Okay, the first question. 45-year-old woman present to the emergency department with shortness of breath, pain on deep breathing, and fever of 1 day duration. 12 days ago, she had a varicose vein surgery. On examination, she has a sinus rhythm with a pulse rate of 110 beats per minute. Her blood pressure is 130 over 90 millimeter per mercury, and her temperature is 38. Pulse oximetry show a saturation of 92% on air. Chest examination is normal. CT BE demonstrate pulmonary embolism. What is the most appropriate treatment? Low molecular weight heparinization, placement of anterior vena cava filter, pulmonary embolectomy, thrombolysis, and warfarinization.
So what's your diagnosis here and what's your answer?
According to the scenario and the CTBA, the patient have pulmonary embolism. I will go through A, low molecular weight heparin.
Low molecular weight. Okay. This question is very, very easy question. Examiners before 2022 till 2021 exam, I can say we had benign examiners. Exams were so easy, like you can see that the pass mark is 71, 72, and many can get more than 85, 85, 86, 87, 88, even 90, and we saw 91, 92, 93 in this exam. Since 2022 exams were literally a little bit or more than tough. 18s, very, very few to see some candidates getting above 80, and very few, more and more fewer getting more than 85. And the pass mark is around 64, 65. Okay. This question simply, he gave you the diagnosis at the end. Okay. Most of questions now, they don't give you the diagnosis. They just give you the symptoms and signs. Okay. And let you guess what is the diagnosis and let you guess what is the answer. So this question can come in different ways. Can come without this one. Can come with just he tell you this and ask you about what is the best investigation to be done. So this will be the answer. Or sometimes he's very benign to put for you this, like the diagnosis or the investigation, and put for you the diagnosis and put. Or he can tell you the investigation, CT, PA is done. What is the most possible diagnosis? So he can ask you about what is the best investigation. He can ask you about what is the differential diagnosis, or what is the probable diagnosis. Or he can ask you about the medication. So this scenario, I can get benefit for it. And I have a patient, middle-aged patient, after 12 days, after a varicose vein surgery. So this patient is in the around 10 days post-operative. So expected the time for pulmonary embolism or for the deep venous thrombosis to happen, not the pulmonary embolism. You can take frankly about a deep venous thrombosis wherever it can happen. It can happen in the lower limb, it can happen in the upper limb, it can happen in the lower limb, then it travels to the pulmonary and so on. So this is a time for PE. This is a time for PE. Let's go for the symptoms. Patient have a low-grade fever and a mild tachycardia. Okay, so patient post-operative, sinus rhythm, mild tachycardia, low-grade fever. So first thing I have to check, and also low oxygen saturation. The patient can have normal oxygen saturation if he has a mild symptom, and this patient is almost have a lower limb DVT. So post-operative, you are as a surgeon, he want to teach you when you go for the ward and the nurse informing you, doctor, I have the patient, this patient, or came to the emergency. He had a surgery 7 to 10 days before, and now the patient coming with a low-grade fever and tachycardia. Okay, even if his saturation is 100%, the first thing you have to rule out is lower limb DVT. This patient comes first with a lower limb DVT. You check his cuff muscles. Almost you'll find this patient have some sort of DVT. Ask for a duplex ultrasound for this patient, compression ultrasound or duplex ultrasound. And then if you rule out this patient have DVT, you can search for any other group. Then after the stage of lower limb DVT, starts this DVT to travel through the venous system until it reaches to the pulmonary embolism, to reach to a stage of pulmonary embolism. Once pulmonary embolism, you'll have these symptoms plus the low oxygen saturation. Okay, what is the best treatment here? Low molecular weight heparin. Low molecular weight heparin. Okay. Low molecular weight heparin. Placement of inferior vena cava filter. No, this is a different scenario. This is a scenario of patient with going to a surgery or a major surgery, and the patient has recurrent pulmonary embolism or recurrent DVT in spite of full heparinization and in spite of full warfarinization. This patient went many times before. This patient is more than 5 years or 4 years taking warfarin, sometimes taking heparin, and the patient many times to have pulmonary embolism. Okay, it is not an important to be a major pulmonary embolism, maybe just mild symptoms or mild pulmonary embolism. Okay, but this patient is still having thrombotic tendency in spite of full heparinization or full warfarinization. So this patient, I want to go for vena cava filter. Pulmonary embolectomy. When I go for pulmonary embolectomy in this patient, why I didn't go for pulmonary embolectomy?
This patient is probably stable.
Perfect. This is stable patient. This is stable patient. Just mild tachycardia, mild fever, blood pressure is 130/90. Oxygen saturation on room air is 92. Unstable patient with low blood pressure, his blood pressure is 90/50 and paper is 100/60, and the patient saturation is in 80, 82, 85, and the patient temperature will be a little same almost. Patient pulse rate is more tachycardia and patient tachypneic. And this patient, when I have unstable patient, I have to go for pulmonary embolectomy. Thrombolysis will be the same like pulmonary embolectomy. Warfarinization, this is a late stage. We can't start warfarin in acute patient. Warfarin is started side by side for the patient on heparin until it started its action, which takes from 3 to 5 days. And then I can stop safely. If the patient is stable, I can stop the heparin, and then I can stop the heparin and continue in warfarin. Okay. What is the only
Dr. Ramy, when do we know, how do we know if we are supposed to choose pulmonary embolectomy or thrombolysis in a situation?
No. This is the same. You don't have, it is not of your scope in MRCS till now, till this day, since more than 10 years exams, to ask you the difference between embolectomy and thrombolysis. Okay, both of them can be happen according to the facility and according to the indication and according to many things. It is out of you till that moment. Even in part B, never they ask you. You can both tell both option for unstable patient. You can say embolectomy or thrombolysis according to the facilities and the patient condition. It is out of your scope in MRCS till that moment.
So we can't have these two options together. That is what you're trying to say.
Yeah, in a stable patient you'll find. In unstable patient you'll find only one. You'll find only one option. Okay.
Okay. Yeah.
I can tell you
Thanks.
simply, we didn't see till now unstable patient. Till now in questions of recalls since 2016, we didn't see unstable patient. All the question of talking with you about stable patient. Okay.
Yeah. Okay. So in a stable patient, we are actually trying to just take a prophylactic measure, or like if is the
yes,
heparin
exactly.
actually.
Yeah, this is a protocol how to deal with pulmonary. Give the patient will be admitted to ITU or ICU, and patient will start immediately on low molecular weight heparin to stop progression of the embolism and at the same time start to regress its size. Type one question. One more question. What is the only condition I can't use low molecular weight heparin here? And in the options, you will find another option. And if you find in the option unfractionated heparin, what is the point you will search in the scenario so you can know when I use low molecular weight and renal impairment? Excellent, Dr. Rune Babikir. Okay, renal impairment. Patient with renal impairment, it is unpreferable or contraindicated in some level of creatinine that you don't use a low molecular weight heparin. And this is more in part B. Or sometimes here, he will tell you if this patient have renal function, impaired renal function, you will find in the options low molecular weight heparin, and you'll find unfractionated heparin. So in patient with renal impairment, go for unfractionated heparin. It's more safe than the low molecular weight heparin. Okay. I just want to move for the next question, next scenario. Okay, Dr. Ali.
Okay. 60-year-old man with ischemic heart disease present with a bilateral gynecomastia. Which one of the following drug is the most likely to have cause problem? Aspirin, atenolol, furosemide, spironolactone, cyroxine. D, spironolactone.
Spironolactone. Some question in the exam, like 1 + 1 = 2. Okay, so you don't have any other, like you you have 1 or 2 question in the exam talking about pharmacology, by the way. Okay, and they are very famous, almost they are very famous and well known. So this question, like nothing needed to be explained, just very common that we know that spironolactone, one of the potassium sparing diuretics we use in especially in hepatic patients, okay, can cause gynecomastia, okay. Question number 3, please.
The next question, 70-year-old man with carcinoma of the bronchus presents with a blurring of vision, headache, and nausea, particularly in the morning. Which of the following is the most appropriate treatment? Carbamazepine, dexamethasone, morphine, elixir, paracetamol, radiotherapy. This patient most likely to have brain mets. So I will choose dexamethasone.
Dexamethasone, okay. Why we give dexamethasone for patient with brain mets?
To decrease the brain edema or to
Decrease the
decrease
brain.
intracranial pressure.
Okay, decrease the peritumoral edema that increase the intracranial pressure. Peritumoral edema that increase the intracranial pressure. This question come in different ways. Okay, sometimes he give you the dexamethasone and ask you why we give dexamethasone, and sometimes he asks you what we give. Very common scenario, almost in every exam. This scenario almost in every exam, whatever it is, a woman with cancer breast, which is more common than the patient with cancer bronchus, most probably female patient, 70 years, with history of cancer breast, came to the ER with headache, blurring of vision, nausea, vomiting, especially in the morning, and this is signs of increased intracranial pressure. Okay, and what the best to give this patient? The best to give this patient dexamethasone. Sometimes he gave you this patient received steroids and improved. Why? Because steroids or dexamethasone decrease the peritumoral edema, so decrease the intracranial tension. This question is very common almost in every exam. Okay, next question.
Okay. A slightly overweight 13-year-old boy present with a 3-week history of right hip pain and limping. On examination, the hip moved into external rotation when flexed. Which of the following is the most likely diagnosis? Obese, 13-year-old, limited internal rotation. This is slip upper femoral epiphysis.
Left upper female epiphysis. Okay, there is no exam without question of slipped upper female epiphysis, question of Percy's disease, plus minus other thing, plus minus DDH, developmental dysplasia of the hip, plus minus septic arthritis. Pediatric orthopedic or pediatric injuries are very important in the exam. We have 4 common scenarios. One scenario about very common slipped upper femoral epiphysis, and one Percy's, and one DDH, and one septic arthritis. Most of them young age patients. Slipped upper femoral epiphysis come in two scenarios. One scenario, frankly, you don't have any question in your schedule study about obese, overweight, 13 years old boy. Don't complete the scenario and go direct for a split upper femoral epiphysis because we don't have any other questions or any other disease related to this child. In one exam in 2022, he didn't bring this one. Say the child, 12 years, as far as and then is suffering from limping, and on examination, his hip moves into external rotation when flexed, or when flexing the hip, it goes externally, and on trial to internal rotation for passive internal rotation of the hip goes in external rotation again. Okay, so he didn't mention overweight, so all candidates were confused. But again, I clear. In this scenario, we have two key words or key phrases. This key phrase is very important and it's the most common. Sometimes he don't bring, he just tell you about, he don't mention here any overweight, and he just tell you on limping, on flexing the hips go into external rotation, and this is a keyword. Percy's disease, almost 7 years old, coming limping. Okay, and nothing else. On examination, there is pain on the hip. Okay, sometimes he tell you X-ray show flattened femoral cap or head. Flattening of the femoral cap or head sometimes, and other times, most of the times, he doesn't mention for you. For any 7 years old boy coming limping, an examination, there is pain on the hip, okay, and didn't mention anything else, so this patient is Percy's disease because it will not be any other thing else. Okay, I always like, if I'm confused between some answers, I can go for some exclusion, like traumatic dislocation of the hip. Do I have any history of trauma here? So don't go for answer. You don't have a reference word for it in the scenario. And if I have here one more option, like if I have here septic arthritis. Okay, I have septic arthritis here. Do I have any signs or symptoms here of infection, fever, tachycardia, leukocytosis? No, I don't have, so I don't go for septic arthritis. Do I have any history of accident or trauma here? So I don't go for this. Okay. Do I have any picture for rheumatoid here? Or is this the age of rheumatoid arthritis? No. Is there any thing regarding the ESR, C-reactive protein, anything related to any markers regarding rheumatoid arthritis, or any aspiration for the joint that show me necrobiotic granuloma? No, I don't have. So it is not traumatic. So I'm between DDH, this and this, and this is obese boys always suffer from slipped upper femoral epiphysis. Okay. Next scenario, and last one, Dr. Ali.
Okay. A patient with locally advanced pancreatic cancer developed persistent back pain. Which of the following is the most appropriate treatment? Corticosteroid, nerve block, non-steroidal anti-inflammatory drugs, paracetamol, transcutaneous electric nerve stimulation. This patient, pancreatic cancer, persistent back pain. So I will go to nerve block.
You go for nerve block. Okay. Very big debate regarding how to manage metastatic disease. Okay. Till now, even the MRCS or the MRCS even books are not clear regarding this, and they started to get one question in 2 exams out of the 3 exams of the year, like giving you patient breast metastatic to the rep. What is the best analgesic? Patient cancer prostate metastatic to the femur. How to manage this patient? But according to the scenario, we will go for the best answer to it. Let's leave it for its discussion with the full scenario. And this scenario is very, very clear. This patient with a locally advanced pancreatic cancer. Persistent back pain. What is meant by persistent back pain? Persistent back pain means even patient with normal painkillers, the patient can't withstand the back pain. So this patient can go for nerve block. Will not know. We know that for pain management, we always follow the pain ladder, pain management ladder. Like we start with paracetamol plus non-steroidal. If the patient is not responding, we can add weak opioids. If the patient is non-responding, we can add more strong opioids. If the patient is not responding, we can go for the interventional pain management like nerve block. So this patient, paracetamol, non-steroidal for management of cancer patient is not accepted. We always start with non-steroidal for the start of pain, and then go for weak opioids, then go for strong opioids, then go for nerve block or other interventional methods. For this patient, even this scenario is, I think it is written in both MRCS and past test. You'll find patient with persistent back pain due to advanced pancreatic. You have to go for nerve block as a palliative management for pain, as a palliative management to let the patient die in peace without any suffering from the tumor or the cancer metastatic pain. So this scenario is very clear to be nerve block. Nerve block. Okay, thank you, Dr. Ali. We can go.
I have question, Dr. Ramy, if this scenario didn't mention the persistent back pain.
Okay, I just want to tell 2 points in this, in your question. Don't try to modify a scenario in front of you you didn't see before in any recall, because if we try to do something like this, we will not finish in modification of all the scenarios. Okay, we have more than 2,000 questions recalls. If we try to modify every scenario, the examiners don't modify the scenario. The examiners almost put the scenario at the same or do another new scenario. Okay, so tell me if he didn't mention advanced pancreatic cancer and he said locally pancreatic cancer, what will be the answer? If he said removed persistent and he put developed back pain, what will be the pain? Okay, if we removed both words and we said a patient with advanced, with locally pancreatic cancer, developed back pain, what will be the answer? So if we try to do something like this for the recalls, you almost need about 1 year to try to finish, and when you go to the exam, you'll find completely new scenarios. The examiners have rich common pool of questions to tell without changing these words. But I can tell you, any pain just started, you can start with non-steroidals. So if the patient of cancer developed, and we have one scenario like this in MRCS, if a patient with cancer, whatever the cancer, he said developed pain, just developed pain, you can start with non-steroidal, but you can't start with paracetamol. Okay, followed by the opioids, whatever weak opioids or strong opioids. But once he magnifies the problem, He magnifies the problem by locally advanced, persistent. You have to go for the extreme of pain management, which is nerve block. Most of the questions for MRCS, he don't give you a gray zone. Okay, he almost give you white or black, white or black. Okay, we mostly give you
Dr. Ramy,
white
can
or
you
black.
just repeat? Can you repeat this? If a patient with cancer develops a new pain, we can start with
Any
like the
patient
basic
newly
pain.
developed, any patient newly developed the cancer, okay, you skip the paracetamol step and start directly with the non-steroidal as a first step on
Okay.
management. Almost this will be a short time, for the patient will go eventually for opioids. If the patient with opioids has no relief and still have persistent pain, you have to go for intervention, pain management, intervention, pain management, which is most commonly the nerve block, okay? Very, very rare or even no questions with gray zone we have till now, okay? We don't have any gray zone questions. MRCS likes you to know the basics of everything, okay? So he won't use this patient have white or black. White, no treatment, black, well, this treatment. The gray zone to confuse you. No, they are not evil to this extent, okay? Yani they are not very evil. They started to make exams very tough, but they started to make the pass mark is much, much lower, okay? Okay, thank you, Dr. Ali. Let's go for who will go after Dr. Ali? Who's raised? Dr. Sana, you raise your hand. Are you ready?
What about the last option?
Yes, I'm ready.
Tense. We don't have question regarding tense till now. Yani transcutaneous nerve electric nerve stimulation. We don't have questions. These questions are used. This tense is used to relieve deep pain through stimulation of nerves on the skin. Okay, the same idea like the referred pain, you know, that you have a pain in the appendix and you refer to the umbilicus due to the same spinal level entrance of the sympathetic nerves. Go for the spinal level of T10, which has the dermatological or cutaneous supply of skin around the umbilicus. You feel pain. So sometimes rubbing the abdomen in this area can decrease and decrease the pain of the appendix pain. And for some theory, like, you know, that like this distraction of the brain about the pain coming from here. The tense working like this, okay? But we don't have any questions till now regarding when to use this tense, okay? Dr. Sana,
Okay.
are you ready?
Yes, Dr. Ramy.
Okay, Dr. Sana, can you go please for question number 6?
A 50-year-old woman sustains displaced distal radial fracture. This is manipulated under anesthetic and treated in a cast for 6 weeks. After 3 months, she returns to a fracture clinic with painful and mimetic pronation and supination. Which of the following is the most likely diagnosis? A complex renal pain syndrome type 1, malignant, non-unit, posterior intratrace nerve palsy, radial nerve compression. This could be a case of malignant.
Imagine, exactly. Okay, this question is very common. You'll find it on almost most of the exams about a patient with fractured distal radius or distal ulnar radius fracture, and then the patient went for a cast for about 4 to 6 weeks, and then the patient came back with pain and difficult movement. This will be malunion. Any fracture, any fraction close to the joint and malunion happen will affect the mobility of the joint. Will affect the mobility of the joint, and this is the most common scenario. And this scenario is very common in exams, and very common in MRCS, and very common in past test. Copy paste, you'll find this question. If it came, it will come like this. There is no malunion. There is no malunion, non-union in other fractures we will study except for neck of femur. Okay, so don't go for any non-union except for patient with fracture neck of femur. Okay, fracture neck of femur. Any other fractures will be malunion. And in this scenario, if you want to modify, he'll tell you patient with fracture, distal tibial fracture, and went for cast for 6 weeks, and then after the patient has ankle pain and difficult movement, so this will be malunion. Okay, so but it came before? No. What is the scenario came about more than 15 times in the last 10 years? This scenario came exactly like this, exactly copy paste like this. Okay, next question, Dr. Sana. Very important question, very important question.
3 days after an isolated head injury from a fall, a 76-year-old woman is admitted for drowsiness and confusion. There are no localizing signs. A CT scan shows a cerebral hematoma on the right side with cerebral swelling and midline shift to the left, a depressed frontal fracture communicating with frontal sinus and signs of infection, an expanding extradural hematoma on the left side with cerebral swelling, blood in the subarachnoid space, and cerebral ventricles with secondary hydrocephalus, cerebral atrophy with subdural collection on the left.
E option, cerebral atrophy with the subdural collection on the left side.
This is an EDH.
This is your answer? Yes.
Yes.
An expanding hematoma. C is the answer.
Okay, let's read the scenario together. 3 days after an isolated head injury from a fall, a 76-year-old woman is admitted for drowsiness and confusion. There are no localizing signs. CT shows expected to show. Very short scenario. Very short scenario. Okay. And expected to see anything of this head trauma or intracranial or cerebral hemorrhage. But why I went for cerebral atrophy with subdural collection? Why I went for this?
Because of the age?
No, I think the 3 days history, that's too long for an extradural hematoma because it presents in a few hours. Like the patient will have confusion, drowsiness within a few hours after the extradural hematoma, and he can have a lucid interval or something, he or she, depending upon whatever the patient is.
Okay. Let's tell you some easy hints and some easy keywords and key phrases regarding intracranial hemorrhage. So from the scenario, once you start, you go run directly for the tumor. Okay, let's start with how many questions regarding intracranial hemorrhage we have? We have subdural hematoma.
4.
We have extradural or epidural hematoma. We have subarachnoid hemorrhage, and we have intracranial ventricular hemorrhage. Okay, this is the 4 scenarios we have. Scenario of subdural hematoma, old age patient with slow progression of the condition. Slow progression of the condition with hazy, unclear history of trauma. Okay. Patient old age, coming to the ED, drowsiness, dizzy. He can't remember he had trauma or not sometimes, but suddenly arrested. Okay. Or he can remember that he hit his head or was in a car crash 3 to 4 days ago. طب why subdural hematoma is very common in old age? If we want to draw the skull like this, and I say the normal, okay, some person, middle age, senile brain atrophy. Excellent. So I have, this is the normal brain. I have what is called diploic veins between the dura mater and the pia mater. Very crossing, small crossing vein like this. Okay. As long as this is between the dura mater and the pia mater here, as long as the brain is filling the skull, so damage of these veins is very rare to happen. It can happen. Yani you can see subdural hematoma in young age, no problem. It is not a must. But I'm telling you, MRCS wants you to know what is the common. That's the common that this happens in old age. Why it happens in old age? This patient and have trauma to the head. Okay, very rare or less common these diploic veins to be damaged. Okay, but let's look for a patient, senile patient. Senile patient, the brain is like this. Senile atrophy of the brain. Okay, so you can find the veins suspended like this. So this patient, even without trauma, just shaking the head, just shaking a head during an RTA can cause these diploic veins to damage and then start to make subdural hematoma. It is a venous hemorrhage. So it is very slow in progression. Very slow in progression. Okay? Very slow in progression. Type. Let's go for the epidural hematoma. Epidural hematoma, young age patient. This is old age. This is young age. Patient around 19, 20, 18, 21. This patient, frank, witnessed head trauma. Very strong head trauma to the side of the head. Plus lucid interval. Plus lucid interval. Plus lucid interval. What happens? The patient, young-ish patient, hit him by a stick, hit him by a ball, hit him by a stone, hit him by any heavy object on the side of his head. Patient loss of his conscious for a few seconds. Then he became normal. Then after a short time, the patient fainted. What is the cause? What will be expected CT finding? Expanding extradural hematoma. Expanding extradural hematoma. Okay. Due to, sometimes he tell you CT finds, CT show extradural hematoma. This will be due to damage of arterial bleeding. Due to which artery?
Middle.
Middle meningeal.
Middle meningeal artery. Middle meningeal artery. That's why it is rapidly progressive. Rapid progression. Okay, rapid progression. This is the second scenario. You can notice when you are going through the recalls, you will notice all of this, what I'm telling you now. Right. Third scenario you have in the exam. Patient with subarachnoid hemorrhage. Patient, young age, around 20, 21, something like this. In a marathon, sudden collapse. Sometimes he tell you sudden development of severe headache or thunder clap headache, followed by sudden collapse. Patient found dead. Okay. Patient is running in a marathon. Very strong headache, followed by collapse. And patient is found dead due to rupture of Beres aneurysm. Rupture, Beres aneurysm. Okay. Last scenario of intracranial hemorrhage. What is the means of this scenario? Anybody knows?
Newborn baby
Immature.
Premature.
Immature or premature newborn found with flaccid and neurological deficits, and you'll find the options extradural, subdural, epidural, intraventricular, or rupture veins, and so on. So you'll find all the options regarding cerebral hemorrhage. One of them intraventricular hemorrhage. We don't have. So intraventricular hemorrhage can happen in adult. Yeah, can happen in young age or old age. Yes, it can happen. But what is the most common? It happens in premature born infant. Premature born infant. So if you go for this scenario, 3 days after isolated head injury from a fall, 76, I will not read the rest of the scenario. I go for the option with the subdural collection. I'll go for the option of the subdural collection. For me, this question in the exam takes from me about 10 seconds. Okay. As usual, I always say in the exam, you have some questions will take from you 40 seconds. Some questions will take from you 10 seconds. Some question can take from you 90 seconds. It is not all the questions 60 seconds, okay? But you have many in the exam, more than 120 questions can take only 10 seconds from you if you follow the keyword or the key phrase policy in the exam. The keyword or the key phrase policy in the exam. Okay. Next question.
A 40-year-old man develops a high output fistula following multiple jejunal stricturoplasties and an ileal resection for Crohn's disease. Which of the following is the most appropriate form of nutritional support? Total parental nutrition should be.
TPN, exactly. Questions regarding nutrition in the exam are very common and almost till now are fixed questions. Okay. One of them is this question: patient with Crohn's disease and have multiple stricturoplasty, plus the patient developed high output fistula. High output fistula equals TPN, equals TPN. Okay. The other scenario regarding TPN is a patient with multiple stricturoplasty or small intestinal resection, and only 5 or 10 or 20 centimeters of the jejunum is anastomosed to the colon. Okay, patient with Crohn's disease underwent multiple jejunal or multiple intestinal resection until only 5 to 20 to 30 centimeters of his jejunum anastomosed to the colon. What is the most appropriate form of nutrition support? This patient will take only TPN. Okay. Then he reverses the question and he said patient resection of 30 centimeters of his ileum due to Crohn's disease. What is the best form of nutrition support? It is not here. It will be normal enteral feeding. Yani 30 centimeters out of about 6 meters of the intestine will not affect the feeding option, because normally if I go for a patient with gangrenous appendix or I can go for right hemicolectomy and I can remove about 10 to 15 centimeters of ileum. Patients of Michel's, I can go to remove about 10 to 15 centimeters of ileum, no problem. Even if I remove 30 centimeters, even 40 or 50 centimeters of the patient ileum, this patient can go post-operative normal enteral feeding. Normal enteral feeding. Okay. No, special formula for this patient, more advanced cases. More advanced case, special formula, and we don't have till now, we don't have question about talking about special formula. Special formula, because patient even only 30 centimeters anastomosed to the colon or removed 30 centimeters of his bowel or his ileum. Okay, this is the question still now. White or black? Gray, this is a very big topic in part B about nutritional feeding or surgical nutrition. We'll study it in part B. Okay. This is the most common question regarding nutrition in this patient. طبعا في very other question regarding head trauma and nutrition head trauma. Okay, so let's keep it when we go through this scenario. Okay, next question.
A 3-month-old boy was born prematurely. He presents with tender, irreducible swelling in the right groin. Which of the following is the most likely diagnosis? It is indirect inguinal hernia.
Indirect inguinal hernia. The most common inguinal swelling in newborn is indirect inguinal. They don't have direct inguinal hernia. They don't have direct inguinal hernia. The most common swelling, inguinal swelling in an infant is indirect inguinal hernia, and this we called as an emergency, not emergency like you have to do it now, or today, but once you diagnose an indirect inguinal hernia in child 2 months, 3 months, as long as the child is fit for surgery, should be done as the nearest operative list to be done. Like we have to do it this week because it is very common to be obstructed, especially in children's when they cry, they push it out. For very, very common complications of inguinal hernia in children, in infants. So once you diagnose patient with inguinal hernia, infant, you have to inform the family that it should be done as soon as possible to prevent complications. So the most common here is indirect inguinal hernia, especially premature children. Last question.
An otherwise healthy 5-year-old boy presents with a 6-week history of minor painless, intermittent, bright red rectal bleeding with no associated disturbances of bowel. Which of the following is the most likely diagnosis? Option D, juvenile rectal polyp.
Juvenile rectal path. Why it is not anal fissure?
No constipation. No const.
Painless. It's the painless.
Painless. Painless. You have a child, 2 questions in the exam. Child 5 to 10 years, okay? One with painful rectal bleeding, and another was with painless rectal bleeding. Sometimes a mass, a bright red rectal mass or a fleshy rectal mass is noticed by the mother during defecation, which disappear after defecation. Happens during defecation and disappears again after defecation. Sometimes recorded by or reported by the mother. And it is a painless bleeding. So this painless bleeding is juvenile polyp. Juvenile polyp, okay? But if he said painful, this will be anal fissure. Anal fissure. طبعا hemorrhoids are not common in this age group. And intussusception is not in this age. What is the age of intussusception?
Less than 1 year.
Less than 1 year, about 9,
6
10
months.
months or
9
9 months. No. It's about 9 months, 10 months, up to 1 year. And the scenario of intussusception, abdominal pain, rectal bleeding, current jelly, blood bleeding, and the child is screaming and crying, and there is a mass palpable in the, there is a mass or a sausage mass palpable on the left, on the right hypochondrial region, very common on the right iliac region, right lumbar region. It's because it's almost very high. And ultrasound can show you what is called the donut sign, the donut sausage-shaped mass, or the donut sign. Donut sign is very pathognomonic for intussusception. And almost 9 months or 10 months old child happens when the patient start to eat. Introduction of new food for the patient, okay? And this new food will stimulate the immunity for the child with hypertrophy of Pierce patch. Pierce patch works as foreign body or lymphoid tissue will work as a foreign body, try to push by the intestine, so intussusception happen. Okay, so it said juvenile rectal. What is the histology of the juvenile rectal polyp? Which type of polyps, of rectal polyps? Hamartomatous. Hamartomatous polyp. Hamartomatous polyp. Very common to ask about hamartomatous polyp, by the way. Juvenile rectal polyp is one or the only example we have of the hamartomatous polyp. Meckel's diverticulum. What is the scenario of Meckel's diverticulum? Or what is the age of Meckel's diverticulum?
About 2 years of age.
2 years, excellent. The most common bleeding per rectum for a patient 2 years with abdominal pain is Meckel's diverticulum until proved otherwise. Okay, the most common bleeding per rectum, a child about 2 years, okay, with periumbilical or central abdominal pain is Meckel's diverticulum until proved otherwise. So now we have 9 months to 1 year or less than 1 year. Intussusception is very common, and we have 2 years. We have Meckel's diverticulum is very common. Thank you, Dr. Adil.
Yes.
Thank you, Dr. Sana.
A 56-year-old woman ventilated in intensive care with increasing oxygen requirements 1 day after elective aortic aneurysm repair. Her pulmonary capillary wedge pressure is 20 millimeters of mercury, which is high, and she has obvious bilateral diffuse opacities on chest X-ray. Which of the following is the most likely diagnosis? Acute respiratory distress syndrome, aspiration pneumonia, lobar pneumonia, pulmonary embolism, pulmonary edema secondary to heart failure. I think probably E, pulmonary edema secondary to heart failure because of bilateral opacities. And also the capillary wedge pressure is high, indicating there's pressure on the heart.
Okay, so this is 56-year-old woman ventilated in intensive care, increasing oxygen requirements 1 day after elective aneurysm, aortic aneurysm repair. Pulmonary capillary wedge pressure, PCWP, is 20, and she has obvious bilateral diffuse scattered opacities in chest X-ray. Okay, so I went for pulmonary edema to heart failure. Okay, according to this scenario, we have two similar scenarios, or one more similar scenario on this. Okay, differential diagnosis of bilateral diffuse opacities in chest X-ray. What is the differential diagnosis of this? Patient with bilateral diffuse chest opacity. What's your differential diagnosis?
It could be DS, it could be aspiration pneumonia as well, but obviously she's in ICU.
No, bilateral aspiration pneumonia is not, in your scenarios in the exam, it will be
ARDS.
upper loop lung apical opacities. In aspiration, very common to happen in the patient supine, so very common to happen in the upper loops. Bilateral diffuse scattered opacities. This is between pulmonary embolism or pulmonary edema and ARDS, acute respiratory distress syndrome. How I can differentiate between both of them?
The pressure.
How can I?
ARDS would occur a lot sooner, maybe.
Sorry?
And acute respiratory distress syndrome would be a lot sooner in occurrence as compared to this scenario because the patient had
Based
and
on
the other, pulmonary capillary wedge pressure is also
pulmonary wedge pressure.
exactly. Yes.
Okay. The main differentiation between both of them, okay, is pulmonary capillary wedge pressure. This one, pulmonary capillary wedge pressure. Okay. In ARDS, the pulmonary capillary wedge pressure will be within normal. You can find it 11, 12, 13, something like this. But in patient with pulmonary edema or heart failure, due to heart failure or pump failure, you'll find it almost 20 or more than 20. He will not give you a gray zone. He will not give you 16 or 17 or 15. Give you 12, 11, 10, or he will give you 20. So, if he didn't give me this one, if he didn't give me pulmonary capillary wedge pressure. How I can expect it is ARDS or pulmonary edema? Look, I tell you, non-scientific hint. Patient old age with history of cardiovascular surgery or history of previous anginal attacks or previous MI. This patient will suffer post-operative and went for a surgery. Post-operative from pump failure, which is heart failure, which can lead to pulmonary edema. So the question or the scenario of the pulmonary edema is almost old age or middle age patient with a cardiac history of MI or previous anginal attacks, or a heart surgery patient with valve replacement, aortic aneurysm repair, okay, post-operative, difficult breathing, low oxygen saturation, requiring more oxygen requirements, more ventilation efforts, and chest X-ray bilateral diffuse opacities. This is a picture of pulmonary edema. Okay, so what is the scenario of ARDS? Till now, we have two scenarios of ARDS. Both of them young age or middle age patients. So young age or middle age patient with RTA, and the patient required massive blood transfusion. He received about 6 to 8 to 10 packs. Then the patient, after 2-3 days, started to suffer from difficult breathing, low oxygen saturation, chest X-ray show bilateral diffuse opacities. This patient is ARDS due to TRAL, transfusion-related acute lung injury. So patient with RTA, what is the other scenario? Acute pancreatitis. Patient with acute pancreatitis. Admitted ITU or ICU. Okay. After 2 days, patient suffered from difficult breathing, low oxygen saturation, increase in the ventilation effort and pressure, chest X-ray bilateral diffuse opacities. What happened? ARDS. Why ARDS here? As a part of multi-organ injury, failure of acute pancreatitis. So the two patients of ARDS are patient young age after RTA or patient young age with acute pancreatitis admitted to the ICU. This is the only two scenarios we have for ARDS till now. Till this time, till the last exam. But what is the scenario of pulmonary edema? As I told you, more older patient, history of MI, history of recurrent anginal attacks, patient history of patient post cardiovascular surgery regarding to the heart, mitral valve replacement, calcific aortic valve replacement, aortic aneurysm repair. All of this, then the patient suffer from this. Almost in this scenario, in the old, he will give you the pulmonary capillary wedge pressure. But if he didn't give me, the answer will be pulmonary edema. Clear?
Yes.
Okay.
Yes.
Okay. Next scenario.
A 75-year-old man is scheduled for abdominoperineal resection for a rectal carcinoma. As part of the enhanced recovery program, he was given a carbohydrate drink the night before surgery. How does pre-operative carbohydrate loading help to improve the outcome of surgery? It decreases the utilization of fat resources. It improves abdominal muscle function. It improves nitrogen balance and reduces insulin resistance. Yes, this one. I think it's C.
Let's see.
Yeah.
Okay. Scenarios regarding enhanced recovery programs, okay, or perioperative enhanced recovery program are very few. Okay. They don't ask you for the details. Some short points and very common to be repeated in every exam. This is one of the most common, and those who finished the MRCS and passed this, you can find this scenario is repeated many times in both of them. Scenarios of enhanced recovery, we can summarize in some scenarios like I will tell you almost all of them they can be for. They always ask about the use of a drain. Okay, so no drain are preferable in enhanced recovery. Use of urinary catheters. No urinary catheter, no drains in general. So even urinary catheter is not preferable in enhanced recovery. Early ambulation is one of the enhanced recovery. Early discharge is one of the enhanced recovery. Early return to oral intake and decrease the fasting time, enhanced recovery. There is no regular use of diazepam or benzodiazepines preoperative is one of the enhanced recovery. So if he tell you the use of regular use of diazepam, no, it is not. It is a wrong answer. Use of antiemetics preferable for early return of the patient to normal diet. Early discharge, early ambulation, early return to normal bowel habits, normal diet. And according to this patient of resection of rectal carcinoma, enhanced recovery, what they prefer, improve the nitrogen. But why they use a carbohydrate loading to improve the outcome of surgery, improve the nitrogen balance and reduce the insulin resistance. Okay. This is the most common. Even no NGT, and here's no NGT tube. Any tubes are not, so no drain, no tube, no urinary catheter. Okay, no urinary catheter. Till now, this is the most common scenarios. I don't know what will happen, and nobody on earth can expect what will happen in the next exam. Nobody. Anyone tell you I have some expectation for the next exam? Okay, listen to him and forget about it. We don't know what is expected. Yani anyone tell you I expect in the next exam will ask about the embryology of the pancreas. Nobody knows. Even the examiners themselves, some of them, yani they put the exam by different examiners put the questions, and other examiners don't know what is the question created by his friend. Okay, so please, when I tell you go study recalls, go study what already we have. Don't expect or don't create new scenarios by your mind and try to answer it, because it will waste your time and distract you more and more. Next question.
In the UK, the National Institute of Health and Care Excellence Guidance recommends that if a person has had a blood transfusion, they should be informed that they can donate blood after a period of 6 months, donate blood after a period of 12 months, donate blood only if tested negative for blood-borne viruses, donate blood when hemoglobin is more than 134, no longer be a blood donor. Okay, I don't have an idea. I'm just gonna guess because UK is very strict, probably E.
Yeah, look, this is a fact in UK. A fact on the health systems there. Okay, and this is, you'll find this question also in MRCS and past test. This is a fact. Any patient, okay, has a blood transfusion, shouldn't no longer be a blood donor anymore. Okay, this is just fact. No, nothing explaining. And this, don't waste your time in this. This one of the questions in the exam that I can say it is a 5-second question. Healthcare in UK, any patient has blood transfusion, just run with your eye and choose no longer to be a blood donor, and then jump to the next question. A 5-second question in the exam. Okay, next question.
A 50-year-old woman presents with a 1 centimeter diameter pigmented, crusting, bleeding lesion on her back, clinically suggestive of a malignant melanoma. Which of the following is the most appropriate diagnostic procedure to be performed? A diagnostic procedure. Excisional biopsy, this one.
Excisional biopsy. Patient with 1 centimeter pigmented, crusting, bleeding lesion on her back, clinically suggestive of malignant melanoma. What is the most appropriate diagnostic? We have to go for excisional biopsy. What is the margins?
Well, depends on the usually
1
dimension, 2
centimeter,
to
1
3
centimeter.
centimeters.
Who said 1
Depends on
centimeter?
it depends on the depth
It's
of
2 centimeters from the
melanoma.
margin.
It's 2 centimeter to 3 centimeters at least, yes.
Who said 1 centimeter? Who said 2 centimeter?
0.5 centimeter.
0.5, okay. Who else?
I think it depends on the depth of the melanoma lesion.
Guys, it is a biopsy. It is a biopsy. It is not an actual, it is not a definite management. It is not a definite management. It is a biopsy. It is a biopsy. You don't know what is the nature of this. He said he is suggestive of malignant melanoma. You are not allowed to take large margin without a proven biopsy. Medical legal. You have a female patient, 50 years or 60 years, with breast mass. You definitely, by your experience, is 100% malignant. You can't go for wide margin excision, or you can't go for mastectomy without a report. Without a report, a pathology report between your hands that protects you medical legally. Any biopsy 0.2 to maximum 0.5 if it is an irregular. Okay, but once I diagnose what is the nature and what is the size and what is the dimension of this, I can go for the definite management with, according to the depth of the and the size of the mass, I can go for a definite management, or what's called completion of excision. Completion of excision. Okay, so here is some in new questions now. You can find excisional biopsy 0.2 and another one excisional biopsy 2 centimeters. The two options, you will find them in the same option. Once I am doing excisional biopsy without a definite diagnosis, I want to go for more than 0.2 centimeter, 0.3 millimeter, and so on. Okay. Who's asking? Someone was asking something. Got the idea?
Yes.
Okay. So don't confuse between definite management and biopsy. Biopsy, just biopsy. Okay. You sure this is a cancer? Yes, I sure. طب why take a biopsy? Medical legal. If you do a wide local excision for a mass, breast mass, without a biopsy, the patient has the whole rights to claim against you that you did a procedure without a proof. Okay. So medical legal, you have a proof that you're going to do biopsy, and then with the biopsy, you can do it intraoperative, frozen section, no problem. You have a proof. And the patient signed the preoperative consent regarding to this intraoperative frozen section, followed by according to the result of the frozen section. The patient know everything before, but you can't do 2 centimeters. It's very big. How you can do centimeter? And then it is benign, and you left for the patient a very big defect. Next question.
A 15-year-old asthmatic man is admitted with a bilateral fracture of fibula and tibia following a road traffic accident. He is on 15 milligram of prednisolone daily and is to undergo surgery the following day. Which of the following regimens should be implemented? Continue normal steroids in the perioperative period. Omit steroids, that's wrong. Reduce steroids on the day of surgery, no. Increase steroids on the day of surgery and for 3 days post-operatively. Increase steroids on the day of surgery and for 1 month following. I think it's D.
D. Increase steroid the day of
Yeah.
surgery and for 3 days
And yeah, 3 days post-operatively.
post-operative. Okay. Why you say this answer?
Because the patient is asthmatic and is taking 15 milligram of prednisolone daily, which is a significant dose. So if we reduce, I mean, I was thinking about A, that continue the normal steroids in perioperative period, but doesn't mention anything about post-operatively, in which we have to increase it to prevent any such events, like because there's a certain amount of stress after surgery, and obviously many other hormones are released. So there has to be a continuation of a high dose of steroid to prevent any other events post-operatively. So that's why I chose D. And 1 month is too long to have a prolonged increase in steroids. That's why I chose D.
Okay. The old protocol for management of patient on steroid perioperative is talking like this. If a patient taking less than 10 milligram daily, no extra doses will be needed. Exactly. We prevent the adrenal crisis. If the patient takes less than 10 milligrams daily, no additional doses will be required, and the patient can go for any surgery, okay, without anything, okay, without anything. So the adrenal can cover this defect through the surgery. If the patient is taking high doses, more than 10, like this patient, 15, the old protocol said if the patient going for a minor surgery, you only have to give the patient an induction dose only of 25 milligram. 25 milligram only in induction. If the patient going to a moderate surgery, you will give this patient the induction of 25 milligram and then continue for 100 milligram per 1 day only, by means 25 milligram 6 hourly for 1 day only post-operative. If the patient going to a major surgery, like the surgery we have here, both bone fracture, the patient should receive the induction dose 25 milligram followed by 100 milligram daily for 3 days, which means 25 milligram 6 hourly for 3 days. The new protocol will be asked in part B, okay, a little bit changed, like all the patient should take an induction dose of hydrocortisone, and to be continued according to the dose the patient is taking, okay, whatever the patient is taking, 5, 10, 15, 20, 30, and managed according to the patient response. Or sometimes he tell you to double the dose in the first 48 hours, then to slowly reduce the dose to the normal regular dose the patient is taking. But till now, this question come like this without any. He didn't write here what is exactly the dose to give, because this is a changed. But what you can say, that a patient going to a major surgery more than 10 milligram, you should give him an induction followed by 3 doses of supportive corticosteroids to prevent adrenal crisis, to prevent adrenal failure or adrenal crisis. Thank you, Dr. Adil. Dr. Mutawakkil, are you ready?
Yeah, ready. 72 years old woman who was treated for breast cancer 20 years ago. Present with tiredness, constipation, back and chest pain. Examination revealed localized tenderness of a thoracic vertebrae and anterior ribs. Her pulse rate is 110 beats per minute and blood pressure 90/60. ECG showed shortened QT intervals. Her biochemistry results are chest X-ray showed lytic lesion in left anterior third, rib, and fifth thoracic vertebrae. Which of the following treatment should be administered first? 0.9% sodium chloride, calcitonin, sinaclacid, bamidronate, prednisolone. I think sodium chloride.
D.
We start crystalloid fluid first.
Sodium chloride first, yes.
Why did you choose sodium chloride? What is your diagnosis here?
Hypercalcemia. The corrected calcium is 3.8 millimole per liter. So first we start a normal saline, then we give bisphosphonate and the calcitonin.
Okay. Very common scenarios in the part A and part B. In part A, how to treat a patient with hypercalcemia. The first line of management, he asks you almost till now, he asking you about only the first line. First line of treatment of patient with hypercalcemia is good hydration of the patient with normal saline. Good hydration of the patient with normal saline. Whatever the scenario is very long. Okay, and give you data and give you normal values and give you actual values and so on. This is a patient. Hypercalcemia equals good hydration of the patient with normal saline. This patient, woman patient with cancer breast, 20 years, presented with, this is the most common scenario, by the way. constipation, back pain, chest pain, tiredness, weakness, muscle weakness. Examination reveal localized tenderness over the thoracic vertebrae and anterior ribs. This is picture of METs. Patient is tachycardic, blood pressure is low, and ECG show shortened QT interval. Shortened QT interval, and this is hypercalcemia. Okay, so all the results here, even if he didn't give you the calcium level for this picture, patient with metastatic cancer breast with picture of shortened QT interval, this is a picture of hypercalcemia. What is the best management here? Good hydration of the patient with normal saline. Good hydration of the patient of normal saline. So any patient with hypercalcemia, first line of management, normal saline, good hydration. Very common. And this is the commonest scenario. Sometimes he gives you the value of the calcium, and he sometimes didn't give you any values. Just to give you the symptoms of tiredness, weakness, sometimes nausea, sometimes constipation, back pain, chest pain, tenderness over the ribs, the ECG finding, and so on. All of this picture is a picture of hypercalcemia that you have to good hydration of the patient with normal saline. Next question.
A previously fit 21 years old man collapses while running a marathon. Resuscitation is
What's your answer?
Subarachnoid hemorrhage.
Subarachnoid hemorrhage. You see, when we use the key answer, what happened? For me, this is enough because I don't have any questions in recalls or any other question bank talking about a 21-year young age patient running and a marathon collapse. I don't have any other answer except for subarachnoid hemorrhage. Okay, continue the scenario.
Postmortem examination showed intracranial hemorrhage. What is the most likely site of the hemorrhage? Extradural, intracerebral, intraventricular, subarachnoid, subdural.
Subarachnoid hemorrhage.
Yeah.
You see, it is very easy. They like this scenario. Yani even till now, examiners are not creative to give any other scenarios except this scenario. And this scenario came about 8 to 10 times before through the last 10 years. Okay. Next question.
40 years old woman present with 2 weeks history of flank pain and episodic frank hematuria. An ultrasound demonstrate 10 centimeter renal mass without hydronephrosis. What is the most appropriate investigation? CT scan, intravenous pyelogram, isotope bone scan, MRI, renal biopsy. CT scan.
He didn't put ultrasound here. Okay, because this is the ultrasound. Yeah, ultrasound here. Any soft tissue mass, okay, in any patient, in your practice, you have a patient came to your clinic. By examination, you can feel by your hand a soft tissue mass, or by listening of stethoscope, you doubt the patient has a mass consolidation. First to start, ultrasound or chest X-ray. Simply, even the insurance will not accept any other investigation if you didn't do the simple investigation. Okay, any health insurance will not accept any advanced investigation. Yani if your patient have a patient with abdominal pain and you doubt this patient has appendicitis and you ask it for a CT scan, which is the most sensitive and accurate investigation for diagnosis of acute appendicitis, the insurance or the health insurance will refuse if you don't have an ultrasound between your hands. You have ultrasound, the ultrasound will tell you this patient has picture of acute appendicitis. So you have to ask, so you can ask for CT, it will be approved immediately. Or ultrasound is inconclusive and the abdomen is full of gas and the appendix non-visualized due to abdominal gases or colonic gases. So CT is recommended. He will ask you for the CT. Here is the same. Patient has a mass, flowing pain, ultrasound, mass. What is the next? CT scan. The best investigation for any soft tissue mass inside the body is CT scan. Okay, especially of the distal rectum MRI is preferable. Patient with a rectal mass, especially the non-peritonized part, you have to go for the pelvis MRI. MRI is the best for the pelvis than the CT scan. Otherwise, CT scan is the best for any other. So this patient has a renal mass, and the best investigation for the renal mass is CT scan. Next question.
A previously fit young man is admitted after RTA. He is satisfactorily intubated because of head injury. He has GCS score of 8. There is no other external injuries, and initial cardiorespiratory stability is achieved during the primary survey. He suddenly became hypoxic after log roll to examine the back. What is the most likely cause of this deterioration? Cardiac tamponade, ongoing major hemorrhage, spiral injury, tension pneumothorax, tracheal tube displacement. The answer is E.
Tracheal tube displacement. Very common silly scenario in MRCS. You are not care enough about the patient. Any patient with an endotracheal tube, you shouldn't move the patient until you ask the person, the ICU or anesthesia patient responsible for this patient, to fix the tube during your examination. Even intraoperative, you want to move your patient, you want to do anything, you want to raise the bed, the table, you want to decrease the table, you want to do any position for your patient, you have to ask the consultant of anesthesia to hold the tube, and he will give you the permission to move the patient. This patient with intubation, and you are careless enough to move the patient to examine him without any precaution regarding this. So what happens? The patient tubular tube displacement happen. This scenario came like this same. The only scenario you have patient log rolling to examine the back. The only scenario you don't have any other scenario. Patient you are examining during log rolling, the patient desaturated due to tracheal tube displacement. Next question.
21 years old man has been hit by cricket ball on side of the head. Initially, he has GCS score of 15. 4 hours after arrival in hospital, while in observation ward, his GCS dropped to 7. His left pupil dilates, and he began to demonstrate extensive posturing of the limbs. What is the most likely change to his vital signs since injury? BB decrease, heart rate decrease, BB decrease, heart rate increase, BB decrease, heart rate normal, BB increase, heart rate decrease, BB increase, heart rate increase.
Increased BP and decreased heart rate.
Okay, give him the chance to answer. So, your answer?
D.
D. Why you choose D?
I think this is Cushing reflex.
Cushing reflex. Okay, what is a Cushing reflex and how it happens?
Increase
You
in
know?
trachea pressure
Okay.
and decrease in heart rate.
Okay, why it happens? Okay, طب in another way, there is some questions tell you why there is an increase in blood pressure in patients with head trauma.
I think the patient actually has an extradural hematoma in this case, so that will increase the intracranial pressure, and because as rightfully so, the doctor mentioned cerebral perfusion. To maintain the cerebral perfusion, the body will try to increase the blood pressure, and that's why the BP will increase. And reflexly, I don't remember why the heart rate decreases. I'm not sure about that. I think it's because that's also because of increased intracranial pressure.
Okay. The first part is, yeah, sympathetic activation. To meet the brain perfusion, BP has to increase. Okay. Cerebral perfusion pressure depend on what? Equals what?
Mean arterial pressure
minus
intracranial pressure.
intracranial pressure. So, the head trauma, what happened? Intracranial pressure started to increase, yeah? Due to edema, due to bleeding. So what will happen? There is a trial. So what will happen here? Some sort of ischemia will happen to the brain tissue. This will activate the sympathetic nervous system to increase the blood pressure, to increase the MAP, so to improve the cranial perfusion pressure. Increase the blood pressure will stimulate the baroreceptors in the aortic arch, and the stimulation of baroreceptors will increase the firing of parasympathetic, which in turn will decrease the heart rate. So sometimes he asks you what happens, what is the changes in the vital signs will happen in a patient with head trauma. That will be increase in the blood pressure and decrease the heart rate and decrease in the respiratory rate, or it will be an irregular respiratory pattern. Right. Sometimes he asks you why there is increase in the heart and the blood pressure. Sympathetic stimulation due to relevant ischemia that happens due to increase the intracranial pressure, in a way trying to increase the blood pressure, to increase the mean arterial pressure, okay, so to overcome and improve the cranial perfusion pressure. Okay, why bradycardia? To increase the blood pressure will stimulate the baroreceptors in the aortic arch, which will increase the firing of the parasympathetic system, which will be reflexes to decrease the heart rate. Decrease the heart rate. Okay? Clear?
Why does the parasympathetic doesn't why doesn't parasympathetic decrease the blood pressure when it's stimulated at this point?
And when stimulated at this point, he will decrease the heart rate. It will not decrease this is a vagal stimulation. It will only decrease
But
the
the
heart rate.
vagus stimulation. Okay.
It will decrease the heart rate, not the blood pressure. So the body try increase the blood pressure, increase the MAP, improve the cranial perfusion pressure. But at the same time, the increase in the heart, this is the reflex. Increase the heart and the blood pressure will stimulate the baroreceptors. The baroreceptor stimulation will cause increase the firing of the parasympathetic, so it will decrease the heart rate. Sometimes we put you another table. Put you another table. Okay. In this table, he writes baroreceptors. Sorry, make it. In this table, you will write baroreceptor, parasympathetic, heart rate. So increase the baroreceptor stimulation, increase the parasympathetic firing, decrease the heart rate. He will tell you increase, decrease. This is another table for Cushing reflex. Another table for Cushing reflex. He will ask you about the baroreceptor. What will happen? Stimulation of baroreceptors. This is mechanoreceptors, which will increase the firing. Stimulation of baroreceptor increase the parasympathetic stimulation. Parasympathetic stimulation will decrease the heart rate. This is the other scenario regarding the question reflex. Okay, clear this point?
Yes.
Okay. Thank you so much, Shabab, for today attendance.